I'll be quick. This is a short presentation, but I do feel the need to educate my Birmingham colleagues before I start. Pinner is a place in East London where you can get your hair cut in the day and stabbed in the night. And probably people in East London would contend that the first accident hospital was actually the Poplar Hospital for Accidents, which was opened in 1896, but we can have a discussion about that later. Anyway, research into practice. This is a bit different from the previous talks this morning, and I guess it's more generic than trauma because it's a big focus at the moment. But when you do research, research has two components essentially. One is knowledge creation, the generation of new understandings or new techniques. The other one is knowledge dissemination, getting that knowledge into practice. And we're much more familiar with the knowledge creation part of it, and we're much less familiar and possibly even bad at knowledge dissemination. And this has been noticed through funding bodies, through government, through policy, through health services around the world now, and there's a lot of focus placed on it. So I'm just going to give you some examples from trauma about how that problem has reared its head in a number of situations, and also a little bit about surgery in general, and then talk about how it may be we should think about addressing it. You take this if you have heavy periods. This is not like an advert at the beginning of a YouTube sketch. This is tranexamic acid. It's cheap as chips. It's an antifibrinolytic. It's available around the world off patent, and it stops you bleeding if you're having heavy periods. And it also stops you bleeding if you give it IV in trauma patients. And we know that because there was a very large, very well designed, very well conducted international multi-center randomized controlled trial called CRASH-2 of antifibrinolytics conducted around the world in 20,000 patients. And they randomized patients pretty well, pretty equally, very well concealed randomization, 10,000 in each group, and significantly reduced risk of bleeding, no increased risk of vascular occlusive events, and overall a reduced risk of death with tranexamic acid, and 1.5% odd absolute mortality reduction. So pretty much a gold standard randomized controlled trial. It's international, it's broadly applicable, it's easy to apply in your own institution, it's based on good background evidence, and yet nobody believed it and nobody took it up, essentially, or the uptake was extremely slow. And all sorts of reasons were put down for why it didn't apply to my patient population. The study was flawed because they didn't include the right patients that are similar to my patients, because they didn't get the same amount of blood that my patients get, because they were enrolled in Nigeria, and Nigerians are different to us. And especially in America, actually, there was almost no uptake of this trial because it wasn't an American study, and Americans are a completely different genetic breed to the rest of the world, as we all know. Then this study came out, Matters, the military application of tranexamic acid in trauma emergency resuscitation. And it's a military study, and it basically compared the outcomes of patients in Bastion who were either treated by British teams or American teams. British teams had already taken up tranexamic acid and were delivering it, and American teams didn't believe in it because they were genetically superior, and therefore they didn't get it because they could already not fibrinolyze or whatever. And this is a retrospective study. It's very low-level evidence, and it found a significant improvement in outcomes for patients who received tranexamic acid. And now it's in all the it's coming into all the American trauma centres, and people are now talking about it positively. It's no longer the CRAP2 study in America. Now they're actually talking about it sensibly and beginning to add it to their formularies. This is a level 3 evidence at best, and actually it could simply be that these patients had a lower mortality because they were treated by British surgeons and not crap American surgeons. I mean, there is enough bias in the study that all sorts of reasons beyond tranexamic acid could be the reason why it worked. And yet this study carried a lot more weight with a lot more people than the big randomized control trial did. And actually you see that everywhere in medicine. Big RCTs, which are denigrated or discarded or inappropriately utilized, despite the huge expense and the huge number of patients that get enrolled into these studies. So there's a fundamental issue about how we use the research findings, how we believe or whether we believe research findings, and how we then implement the findings of research into our own practice. So even though CRASH2 is out, even though MATTERS is out, there are some people who say, you know, I want evidence of fibrinolysis. I want to see that blood isn't clotting on one of these machines before I give the drug. Never mind that the drug was given in Colombia to everybody who came through the door who might have been bleeding, where they're never going to get Rotem machines. They will certainly not in the near future. But no, there are people with their own biases and their own understanding who say it doesn't matter what an RCT says because I know that this is how we should treat these people. My own personal biases or understanding says that I can't apply the RCT to my patients. And then another example, of course, of research that has led to huge changes without what we would understand as good quality research is the use of high-dose plasma in hemorrhage resuscitation. Only retrospective trials have been published, not trials even, retrospective cohort studies have been published, and pre and post introduction of massive hemorrhage protocol trials have been published on this, and yet massive uptake around the world, huge increase in demand for blood stocks and plasma stocks in general, to the point essentially where we are now having to buy in our AB plasma from the United States because we don't have enough in this country anymore, or there are times when we will not have enough AB plasma in this country. And yet, very little evidence in trauma, almost no evidence in anything outside of trauma, and yet extrapolated for all sorts of reasons into clinical practice. Tranexamic acid has actually got a good evidence base for its use in elective surgery. There's very good evidence, summarized in this systematic review by the Cochrane collaboration, that tranexamic acid reduces blood use in all elective surgery, hip surgery, prostate surgery. It's been trialled in a number of conditions. Here's the funnel plot from that thing. Yet almost nobody uses tranexamic acid routinely in their elective surgery. And this data has been out for a long, long time. So there are reasons why these things don't get into practice, essentially. And it's beyond trauma into some things like the fundamentals of surgery, bowel prep. Huge amounts of evidence that say that bowel prep is not useful, may be harmful, and yet day in, day out, patients get bowel prep. And actually, it seems that the more ingrained a practice or the older a practice, the harder it is to change when new evidence comes out. So when I was in the US on my fellowship there only a few years ago, the abdomen is still closed with interrupted sutures in most places in the US. A lot of the places in the US still do bowel anastomoses with catgut and silk, 2 layers. I nearly got crucified for doing running mass closure when I first started. The European way, it became known as. But these are all things that are ingrained into surgical practice and very difficult to change. Whereas if you have some fancy new technology that has no prior art, if you like, to fight against, it'll be taken up with relatively little evidence requirement behind it. And we've seen this more and more. Guidelines are one way of getting research into practice. You do your research, and we're all used to developing guidelines, consensus conferences, putting out guidelines and things. And they certainly have a place, and they certainly do well in terms of getting stuff into practice. But it can take a while to pull guidelines together because the process of guideline development is relatively inefficient. Consensus conferences of experts tend to not be run along standard methods that you would understand as a good way of addressing evidence-based evidence that is out there. And of course, it can take so long to rewrite guidelines that they can actually hinder the process of uptake. And coagulopathy that was mentioned earlier has been hindered by the prevailing American College of Pathologists and British Society of Haematology guidelines about requiring prothrombin tests before you issue plasma for years and years and years. And then there's something about systematic reviews themselves. We are all taught that the systematic review is the highest possible level of evidence synthesis, and that the meta-analysis is the highest possible level of evidence. But these things come out, and they don't really change our practice, or at least not quickly, and at least not easily. And probably because it's not the way that we learn. You know, we learn, or we are evolved to learn like this. We learn through stories, essentially. We don't often, as surgeons, sit around the campfire, but we sit in the bunker regularly, or more often we hear and learn stories from our colleagues or our bosses around the operating table, and that's what we're programmed to learn. And we're told that we mustn't take note of the anecdote, and yet the anecdote carries much more weight for us on a personal level than any systematic review that we read. So we have to try and understand how we can teach the results of evidence-based medicine through the use of story in one way or another, and get much better at ingraining this in our trainees and in ourselves. And there are all sorts of things out there that can help us do that now. One thing that helped the uptake of tranexamic acid was the production of YouTube videos about its use disseminated widely around the world. It wasn't a very good video. It wasn't as good as this video, which many of you will have seen, but if you haven't, I would recommend that you learn how to do CPR from Vinnie Jones. But this arguably has done much more to push out the fact that you don't need to do mouth-to-mouth anymore, and it's just closed chest compressions, than anything else around the world. And this certainly has gone viral and got messages out. And there are all sorts of ways of interacting now, not just with each other, but with the public as well, where if the public are asking you to change, then you essentially have to change in one way or another. And we also probably need to get a lot brighter at understanding how we can help clinicians apply the results of a randomized controlled trial to the patient that they've got in front of them. Because ultimately, the randomized controlled trial tends to the average. It's the average case, the average patient, and you get average effect for the treatment applied to the inclusion group. The patient you get in front of you is not average, and how you apply that in a many-to-one relationship, we need to understand a bit better. So apparently there's a science to all this. It's called implementation science, and you can find implementation science in such journals as the British Journal of Psychiatry, which is a difficult place to read. But it does have some structure about what the barriers to getting research into practice are. But it's a bit nebulous, I have to say. But it is a big push from the funders at the moment. And there are active funding mechanisms out there now to understand what the barriers are to getting research into practice and how we can get better at pushing research through into practice in a much faster timeline. We ourselves in the trauma sciences group at Royal London have developed this public and policy core, which is looking at research dissemination, and hopefully we'll be looking at barriers to the uptake of trauma as well. But in terms of surgery in general, I think there's a huge opportunity to look at how we get surgeons to understand research better, understand what that forest plot is on the systematic review, and how to apply it to our own patients. Thank you very much.